of 7, we are supposed to be covering acute kidney injury and chronic kidney injury, whereby I will cover acute kidney injury, I will be covering chronic kidney injury. So, kidney injury is a sudden and rapid decline in the kidney function, and it can be reversed. It can be caused by several causes, which include reduced blood flow. We have nephrotoxins and obstruction of the urinary tract. So it's abrupt which occurs within hours, and it's rapid. Then we have the causes, which include reduced blood flow, which is the hypoperfusion of the kidney. This can be caused by dehydration, heart failure, or shock. Then we have damage to the kidney cells, which can be defined as nephrotoxicity from medications. The medications can include angiotensin-converting enzyme inhibitors, or the NSAIDs, or the infections of the kidney, the nephrons. Then have obstruction of the urinary tract. Then we have several risk factors, which include underlying medical conditions like kidney disease, heart failure, diabetes mellitus. Then we have older age due to kidney decline. Stephen, please. We are under risk factors. So we have clinical situations like sepsis, which is an infection, then urinary tract obstruction. We have hypovolemia, hypotension, dehydration, and reduced fluid intake. Then have nephrotoxic medications, which include the nonsteroidal anti-inflammatory drugs, the antibiotics, diuretics, and specific medications like the ACE inhibitors. Then have three main types of acute kidney injury, whereby we have pre-renal, intrarenal, and post-renal. Whereby pre-renal occurs is caused by a condition which does not involve the kidney directly, whereby we talk of reduced blood flow or ischemia. Then intrarenal, these are conditions which affect the nephrons. Then post-renal, this is caused by an obstruction in the urinary tract. So when we focus on pre-renal or pre-renal azotemia, it's the most common type of acute kidney injury, results from decreased blood flow to the kidneys, which is renal hypoperfusion, without direct damage to the kidney itself. So the kidney tries to compensate for the decrease in blood supply. Therefore, under pathophysiology, we have hypoperfusion, where the kidney does not receive enough blood flow, or the blood does not have enough efficient oxygen, which is caused by conditions like hypovolemia, low cardiac output, systemic vasodilation, and renovascular diseases like renal artery stenosis, which is the narrowing of the renal artery. This leads to insufficient blood supply to the kidneys. Then we have renal autoregulation. So since the kidney does not receive enough oxygen supply, it tries to maintain its glomerular filtration rate. So it achieves this through two means, whereby the afferent arteriole dilates and the efferent arteriole constricts. So prostaglandins cause the afferent arteriole to widen, increasing blood flow to the glomerulus. So after dilation, more blood moves through the glomerulus. Then the efferent arteriole constricts, which increases the pressure. Then there's more filtration. Then we have neurohumoral activation, whereby this is through the RAS and the ADH relays. So the RAS tries the RAS, renal angiotensin aldosterone system. This leads to constriction of blood vessels, which increases the blood pressure, and therefore this tries to increase the blood flow to the kidneys. The aldosterone helps in reabsorption of water and sodium. Then have release of antidiuretic hormone of the vasopressin, whereby the low blood volume stimulates ADH release, which increases water absorption in the collecting ducts. This leads to concentrated urine. So if this ischemia is prolonged or the reduced blood supply, this can lead to ischemic damage of the kidney tubules, transitioning to intrinsic acute kidney injury, especially the acute tubular necrosis. So the renal or intrinsic acute kidney injury is caused by direct damage to the kidney parenchyma, which are the functional cells. It affects the tubules and the renal vasculature. Under physiology, four main ways through the renal tubules are affected. We have acute tubular necrosis, acute interstitial nephritis, glomerulonephritis, and vascular injury. So under acute tubular necrosis, which this results from prolonged or severe ischemia or nephrotoxic agents, whereby we have ischemic acute tubular necrosis and nephrotoxic acute tubular necrosis. The acute tubular necrosis results from hypoperfusion, which leads to hypoxia and ATP depletion in the renal tubular cells, particularly in the highly metabolically active proximal tubules and thick ascending limb in the outer medulla. So this causes several reactions, whereby you have cellular injury and death, whereby necrosis and apoptosis of the tubular epithelial cells. So these tubular epithelial cells form rush borders, which produce some of the renal enzymes, renal hormones, thereby have impaired reabsorption of substances. Then we have tubular obstruction. Then we have back leak of filtrate, whereby the damaged tubular epithelium allows filtered fluid to leak back into the interstitium, further reducing effective filtration. This can also lead to swelling or edema. Then we have injured cells release, which cause inflammation through the infiltration of leukocytes and release of cytokines and chemokines, which contribute to further injury of the nephrons. Then we have vascular dysfunction, whereby endothelial cell injury and persistent vasoconstriction of renal vessels exacerbate the ischemic damage, especially in the outer medulla. So that was caused by the hypoperfusion. Then you have nephrotoxic agents, which cause injury to the nephrons, whereby you have direct toxic effects of exogenous substances like aminoglycosides or endogenous substances like hemoglobin from hemolysis on tubular cells. So the high blood flow and concentrating ability of the kidneys make them susceptible. Then have acute interstitial nephritis, which is inflammation of the renal interstitium, often an allergic reaction due to medications like penicillins or infection. This involves an immune-mediated response leading to interstitial edema and inflammatory cells infiltration, which can compress the tubules and impair the renal functions. Then have glomerulonephritis, which is inflammation and damage to the glomerulus, which can be primary renal disease or part of systemic diseases. Example is lupus. The damage to the glomerular basement membrane and capillaries impairs filtration and can lead to hematuria, which is excretion of blood in urine or excretion of proteins in the urine, proteinuria. Then we have vascular injury, whereby this is the damage to intrarenal blood vessels, which reduces renal perfusion and glomerular filtration rate, which can be observed in conditions like malignant hypertension. Then we have cellular and molecular mechanisms in intrinsic acute kidney injury, whereby we have mitochondrial dysfunction, whereby the ATP production is impaired, which leads to dysfunction of the ion pumps, especially the sodium potassium. Then this leads to cellular swelling and loss of cell integrity. Then have oxidation stress, whereby ischemia, reperfusion injury, and toxin exposure leads to generation of reactive oxygen species, causing damage to cellular components like lipids, proteins, and DNA. Then there's inflammation, which contributes to ongoing tissue damage and impaired repair. Then there's apoptosis, which together the necroptosis, which is a combination of necrosis and apoptosis, and ferroptosis, which is ion-dependent cell death, contributes to tubular cell loss. Then we have endothelial dysfunction. The damage to endothelial cell lining and renal microvasculature can lead to vasoconstriction, which reduces blood flow and microthrombi formation, which increases the injury. Then we have postrenal acute kidney injury, which is caused by obstruction of the urinary tract. Under its pathophysiology, we have reduced renal blood flow, whereby there is increased intratubular pressure, which compresses the renal blood vessels, leading to reduced blood flow in the renal tubules. And this leads to ischemia. Then the increased intratubular pressure, which is caused by obstruction, which is caused by backflow of urine, increases the pressure within the renal tubules and the Bowman's capsule. This counteracts the glomerular hydrostatic pressure, reducing the net filtration pressure, and thus the glomerular filtration rate is reduced. Then there's inflammation and fibrosis, whereby the prolonged obstruction can lead to inflammation, which is the response of the nephron to the injury. Then we have tubular atrophy and ultimate fibrosis, which causes irreversible kidney damage. If not relieved. Common causes of the postrenal acute kidney injury include kidney stones, benign prostatic hyperplasia, bladder cancer, urethral strictures, neurogenic bladder or external compression, PG of the ureters. Then we have signs and symptoms. We have a chart which summarizes the three types of acute kidney injury. Then we have signs and symptoms. So the signs and symptoms, we have the early and general signs, then we have the later signs which are more specific. So under the early and general symptoms, we have decreased urine output, the oliguria, we have fatigue and weakness, we have nausea and vomiting, we have loss of appetite, general body aches, diarrhea, dehydration, which is mostly in prerenal acute kidney injury. Then have later and more specific symptoms, which develop after the condition takes some more hours or days. Then have under the more specific symptoms, we have swelling, the edema, we have shortness of breath, we have high blood pressure, the hypertension, we have the chest pains or pressure, we have muscle weaknesses, we have itchy skin, abdominal distension, we have headaches, seizures or coma, among others. Then we have phases of acute kidney injury, which are 4. We have onset or initiation phase, we have oliguric or anuric phase, we have diuretic or polyuric phase, and recovery phase. So under onset, this is the situation where the kidney is prone or kidney is there's reduced blood flow or we have the toxic substances. Then oliguric, this is now the effects start affecting the nephrons. Then under diuretic, the kidneys are trying to recover from the effects. Then the recovery where the kidneys recover their normal functioning. So I've done with acute kidney injury. Thank you.
Okay, good evening. I'll be taking you through the chronic kidney injury, or it's also called the chronic renal disease or the chronic kidney failure. So, the chronic kidney injury is defined by the presence of kidney damage or decreased kidney function for at least 3 months. It is a long term condition characterized by the gradual and progressive loss of kidney function over months or years. So, unlike the acute one, which is a sudden decline, the chronic one is just a slow and often irreversible process where the kidneys become increasingly unable to filter waste products and excess fluids from the blood. We have the causes of the chronic kidney disease. First, we have the diabetes, we have high blood pressure, glomerular disease, polycystic kidney disease, obstructive nephropathy. We have recurrent acute kidney injury, autoimmune diseases, we have certain genetic disorders, and also long term use of certain medications. And then when you go to the risk factors of the chronic kidney disease, we have major chronic diseases such as diabetes and hypertension. So, diabetes actually leads to high blood sugar, which damages the kidney blood vessels. And then hypertension actually is the second leading cause, and as the uncontrolled pressure damages kidney blood vessels. Other kidney specific conditions, we have the glomerular disease, such as the inflammation of kidney filters, polycystic kidney disease, and then recurrent kidney infections and long standing urinary tract obstructions. We also have previous acute kidney injury can also lead to chronic kidney disease. We have lifestyle factors such as obesity, smoking, and long-term abuse of certain medications. We have non-modifiable factors such as older age, family history of kidney disease, and certain ethnic backgrounds. Then we also have the pathophysiology of the chronic kidney disease. First, we have the progressive loss of nephrons. So, the chronic kidney diseases are actually characterized by a gradual reduction in the number of functional nephrons, leading to a decline in the glomerular filtrate rate. The loss in the nephrons can be caused by various factors such as glomerulosclerosis, interstitial fibrosis. So in the glomerulosclerosis, it's just the scarring or thickening of the glomeruli. The glomeruli are the small blood vessels within the nephron due to factors like high blood pressure, diabetes, and proteinuria. When you come to tubulointerstitial fibrosis, it's just the damage or scarring of the tubules and the interstitial tissue surrounding the nephrons, often caused by prolonged inflammation, ischemia, or toxic insults. And then on the vascular sclerosis, which is another factor, we have it's just the hardening and narrowing of the blood vessels supplying the kidneys, leading to reduced blood flow and oxygen supply to the nephrons. And then we have the next point, we have the renal functional adaptation and compensatory hyperfiltration. So initially the remaining functional nephrons, which were not maybe affected, may compensate for the loss of the increasing their filtration rate, hyperfiltration, and also the size, hypertrophy. However, this compensatory mechanism is not sustainable and can actually worsen kidney damage over time. We have disruption of fluid and electrolyte balance. As kidney function declines, the kidney loses the ability to effectively regulate fluid, volume, sodium, potassium, and phosphorus levels. It can lead to fluid retention and also electrolyte imbalances such as hyperkalemia, that is high potassium, and then high phosphorus or low calcium, which can affect heart function, bone health, and other organ systems. We have metabolic acidosis. The kidney's inability to effectively excrete acid waste products can lead to metabolic acidosis, causing systematic inflammation and bone loss. We have uremic toxins and systematic complications. So the accumulation of waste products in the blood, that's uremia, due to impaired kidney function that can cause various systematic complications, including anemia, cardiovascular disease, neurological dysfunction, skin and bone problem. And then we have factors contributing to the progression of chronic kidney disease. We have hypertension with the high blood pressure, and then diabetes, and then proteinuria, inflammation, genetics factors, and environmental factors. And then lastly, we'll talk about the signs and symptoms. So first we have the general signs and symptoms such as fatigue, weakness, poor appetite, nausea, vomiting, and a metallic taste in the mouth. So you have fluid imbalances because the kidney cannot perform its function well. We have swelling in the legs, ankles, and face. We have shortness of breath due to fluid in the lung. We have hypertension, and then urine output may change, becoming more frequent, especially at night in earlier stages, then decreases significantly later on. We also have uremic effects, that is toxin buildup. We have neurological, such as confusion, difficulty in concentrating, muscle twitching, restless legs, and in severe cases, seizures. We have the cardiovascular effects such as chest pains, irregular heartbeats, and increased risk of heart disease. We have the hematologic effects such as anemia, and then an increased bleeding tendencies. On the skin, one can um, one can experience dry, itchy skin, and then skin discoloration, and in rare severe cases, uremic frost. And then mus- musculoskeletal signs and symptoms. We have bone pain, joint pain, and increased fracture risk due to mineral and bone disorders. That's the end. Thank you.
Thank you. Chronic, acute and chronic kidney disease. The acute kidney disease, which involves various factors. The major causes, as was discussed. I hope you hear me right. Okay. Yeah, so as was discussed, we have the causes for the acute kidney disease being classified into three. We have the pre-renal causes, the intrinsic or intrarenal causes, and also the post-renal causes. So when talk about the pre-renal causes, which are actually the most common causes of acute kidney injury, this one usually is any effects that happen before the kidneys. So anything that happens that affects the blood volume, just before the kidneys is the pre-renal. So usually that causes reduced renal perfusion without directly causing injury to the kidneys. Now, anything that's going to affect blood volume flow to the kidneys, then that means that now when we talk about the pathophysiology, we'll be talking about decreased blood volume or decreased blood pressure, which could be as a result of hemorrhage, could be as a result of dehydration, heart failure, and that can affect the blood volume. Now, if there's reduced blood volume, then there will be now decreased renal perfusion because of the decreased blood volume. With decreased renal perfusion, there will be decreased glomerular filtration rate. And now, of course, with that, compensatory mechanisms will be activated, as the first presenter said. The RAS system will be activated. Vasoconstriction will happen just to try to maintain the glomerular filtration rate. But now, if there is going to be prolonged hypoperfusion or prolonged decreased blood flow to the kidneys, then that's going to lead to ischemic injury. That means it's going to lead now to injury to the kidneys, and that now moves from being prerenal kidney injury to the intrarenal or the intrinsic kidney injury, because now prolonged hypoperfusion or prolonged limited blood flow is going to affect the structures of the kidney. So that means now when there is direct damage to the kidney tissues, the tubules, the glomeruli, the vessels, those are now the intrarenal or the intrinsic causes of acute kidney injury. Usually the acute tubular necrosis is one of the most common, which is caused by ischemia because of the prolonged hypoperfusion, or caused by nephrotoxins like drugs, which of course with the exposure to drugs, to prolonged hypoperfusion, there'll be tubular cell injury for the various kidney tissues. There'll be necrosis, can lead to tubular obstruction. There'll be further decrease in the glomerular filtration rate, which could be as a result of now backleak of the filtrate or obstruction or the vasoconstriction. Some of the other causes, like of course the glomerulonephritis, which again affects the kidney structures. Then the post-renal, usually that's after the kidneys now, where there is obstruction of urinary outflow. If there's obstruction of the urinary outflow, there'll be increased intratubular pressure, which again is going to cause decreased glomerular filtration rate. With the prolonged obstruction, there'll be tubular atrophy because of now, of course, the increased intratubular pressure, and that's going to affect again now the kidney structure. So one of the things that we commonly see with that kidney injuries, acute or chronic, there'll be reduced glomerular filtration rate. That's one of the kind of things that you'll get to see in such. So there'll be various stages: initiation phase, when there is increase and insult the kidneys, which leads to decrease the GFR, which can be detected earlier. But now, if it's continuous, then there will be, of course, continued hypoxia or continued hypoperfusion, which can lead to cell death. But again, if for acute kidney injury, usually we refer to as the reversible kidney injury. All you need to do is to manage the causative factors. What has caused the prerenal causes? Was it hemorrhage? Arrest the hemorrhage. Was it heart failure? You get to manage the heart failure. So you get to manage the cause. If it's glomerulonephritis, manage that. If it's post-renal, you're talking about obstruction, get to manage that, and you're able to reverse the injury to the kidneys. For the chronic kidney injury, usually now this is the what we call the irreversible kidney injury, where now there is damage to the kidney structures, and eventually, progressively, the patient experiences now irreversible loss of the kidney function. Usually can progress over months to years, eventually affecting now the kidney's ability to maintain fluid, electrolyte, and waste balance. So usually now, the pathophysiology of the chronic kidney disease, when there is initial kidney injury, which can be brought about by the various diseases like diabetes mellitus, one of the leading causes of chronic kidney disease, the hypertension, the glomerulonephritis, the polycystic kidney disease, prolonged obstruction or prolonged acute kidney injury will be some of those causes that can progressively cause the chronic kidney injury. Now, exposure to those causes, initial causes, there'll be now nephron loss. That's now the loss of the functioning of the nephrons. Maybe those that are not lost or are affected, they'll hypertrophy. They'll try to hyperfilter because they are trying to compensate for those that have been lost or that have been affected. And that leads now to glomerular hypertension, which leads to increased glomerular permeability. There will be proteinuria, further damage to the nephrons, and it becomes a vicious cycle that keeps on repeating. So once some of the kidney structures lose their function, those that have not lost their functions now, of course, will now have to increase their activity. They'll hyperfiltrate, they'll hypertrophy just to try to meet the increased demand, but also over time, they also get to fail. So that's why progressively now, you find that the whole kidney structures are getting affected. So, of course, with that, there'll be decline in glomerular filtration rate. There'll be accumulation of wastes, the urea, the creatinine, the phosphates, the hydrogen ions, which can easily now lead to metabolic acidosis. The uremic symptoms will also present here because now of the increased levels of urea, like the fatigue, the nausea, and over time, now one develops systemic complications. And if you wondered, and I'm sure they was talking about some of those systemic complications of chronic kidney disease, it virtually affects almost all the body systems. The cardiovascular system, there'll be hypertension, there'll be heart failure, atherosclerosis will come in, hematologic anemia will come in. Remember now, with the chronic kidney diseases now, with the effects or the damage to the kidney structures, remember the hormone erythropoietin is produced from the kidney. So with the damage now, there'll be decrease in the erythropoietin. So anemia will present in. There'll be renal or dystrophy because of decreased vitamin D in the body. And with decreased vitamin D, there'll be elevated parathyroid hormone levels. So which will affect now the skeletal muscle systems. Electrolytes, there'll be hyperkalemia and hypocalcemia. Metabolic acidosis, which we just talked about, some of the effects of the increased urea substance in the body. One also will present with some of those is a pruritus, which is a dermatologic problem. So progressively now, one gets to lose their kidney function. And usually what you need to have at the back of the mind is now, when it's chronic kidney disease, the damage to the kidney structures now is irreversible and it's progressive. But now early detection and control can slow down the progression. So like with early detection, now you're able to manage the BP, blood pressure levels, you're able to manage the glucose levels, the proteinuria. That slows the progression. But if it's discovered late in its stage, then now one progresses to what we refer to as the end stage renal disease. And end stage renal disease now will require one to undergo dialysis, where probably the kidney structures have been affected to the point that they're not able to filter properly, so have to go undergo dialysis or can undergo kidney transplant. Question on acute kidney and chronic kidney.